I'm going to talk almost exclusively about off-label use because the current labels are medieval and should have been changed years ago, but they haven't been. So I want to take you through a new paradigm to approach iron deficiency. Iron deficiency is not sexy like leukemia, lymphoma. Even thrombosis is much sexier than iron deficiency. But it is the commonest malady on the planet. There are more cases of iron deficiency than all malignancies combined. So it's relevant, and it makes patients feel bad. And I think what you're going to see are some evidence that the way we manage iron deficiency needs to be revisited. So I want to start with some folklore. The likelihood that anaphylaxis will occur with any of the agents, if you understand the nature of the minor infusion reaction, is vanishingly rare. So I put this slide first. Labile-free iron is what's responsible for the majority of reactions that you see. It may be a complement-mediated system that now is being investigated further, but whatever it is, these are minor, transient, harmless reactions that disappear without therapy. On the other hand, the extremely rare immune reaction that will lead to anaphylaxis, which you see on the right, and these are published symptoms in both categories, does require urgent intervention. I think I've treated about 45,000 people now since 1981 with IV iron, and we have not seen a single one of those, with the exception of one of two patients who received high molecular weight iron dextran that's not available anymore. So this minor reaction, which we'll go over a little bit more in detail, should be just observed, and I'll show you what happens. But remember these symptoms. Remember what you might do if this reaction occurred in somebody that you were taking care of. And here is the evidence to support it. When you inject these compounds, labile-free iron is released, otherwise it wouldn't work. You need that iron to load transferrin, and there's a huge difference in the amount of labile-free iron in the drugs that were available years ago to what are available now. On the left, iron gluconate and iron sucrose have by far the highest amount, and I'm not going to discuss these much further. They're fine for dialysis and chemotherapy-induced anemia, where effectively you have medical prisoners who come once a week or 3 times a week, and you can give them this drug seamlessly. But for the patients with heavy uterine bleeding or pregnancy or inflammatory bowel disease or gastric bypass or Osler-Weber-Rendu who come in one time or even have to travel to you, you can give them a complete replacement dose in 15 to 60 minutes and do just as well. And also, if you even take a look on the right side, you'll see that even though they're much lower, they're not zero, which talks about the imprudence of giving high doses of any of these drugs in a very short period of time. So this is what's available in the U.S. Isomaltoside is only Europe, so I won't discuss it further today. Low molecular weight iron dextran can be given as a gram in an hour safely. We've given over 6,000 of those. We published it. It's an up-to-date. It's off-label. 100 milligram dose is the only approved dosing of this. I never, ever use 100 milligrams of low molecular weight iron dextran. It would take 10 visits to do what I do in one, making the likelihood of infusion reactions and extravasations 10 times higher. It is a ridiculous label. It's all bad without benefit, and I don't know why it doesn't get changed. Ferric gluconate and iron sucrose are good drugs. They're safe. You can't give more than 200 to 300 milligrams, or else you cause a fair number of minor infusion reactions that are very aggravating. But for dialysis patients and chemotherapy-induced anemia, this is driven by markets, and it depends what your contracts are. Since iron sucrose is sold by DaVita Dialysis in the United States, it's very unlikely that the 475,000 dialysis patients will get a different iron. Ferumoxytol is a very cool drug, but they really made an error when the drug was first released. It came out as a 17-second infusion of 510 milligrams, and as a result, the labile free iron was too high, and there was a misperception that this drug caused a lot of anaphylaxis. It doesn't, but if you give it in 17 seconds, you're going to see a lot of minor irritating infusion reactions. But this drug came out as an MRI dye, and I predict in the next 2 years it will replace gadolinium completely, which is going off the market. So if you use this drug, which is approved only in the United States for patients with chronic kidney disease, you need to let a radiologist know that you gave it. They love it. However, it does make the image hotter. And iron carboxymaltose, which is the newest agent to be approved, can be given as a 750 milligram infusion. In 15 minutes. Excellent drug, very safe, just like the others, but it is 5 times the price of low molecular weight iron dextran, and Ferumoxytol is more than twice the price. The difference in a chair between 15 and 60 minutes now is $27, at least in Baltimore. These are the FDA-approved indications, which I told you. Iron dextran and ferric carboxymaltose have a broad indication, and Ferumoxytol only in chronic kidney disease. This is the way I recommended it be given next to the approved. I think that a gram of low molecular weight iron dextran in an hour is a marvelous way to give the drug. It costs $234 a gram. Ferumoxytol is a terrific drug. After they got into trouble with the 17-second infusion, there was an overreaction and they moved it to 15 minutes. We gave 90 doses at 17 seconds and had 3 episodes of hypotension. The last 2,500 doses have been given over 3 minutes. We've seen none. I don't know if I should talk about myself, but I had a bleeding ulcer, and I gave myself 2 3-minute infusions of Ferumoxytol. It was terrific. Ferric carboxymaltose can be given as 750 milligrams or 1,500. This drug costs $1,134 a gram. It's a great drug. It has very few reactions, but you either give 750 or 1,500. In Europe, they have a 500 and 1,000 milligram vial, and my fingers are crossed big time that we'll be able to give 1,000 milligrams of this drug soon without having to waste $500. So since I'm going to talk about a number of conditions where I think oral iron should be proscribed, I think we should talk a little bit about the data in randomized studies of patients who had oral iron. If you take a look at this forest plot, the overwhelming majority of patients report, that's more than 70%, significant gastrointestinal side effects compared to placebo in randomized controlled studies. We learned in medical school that oral iron is well tolerated. That's nonsense. You're all doctors. You know the side effects of oral iron. The overwhelming majority complain of GI perturbation, especially constipation and metallic taste. So for individuals who have significant iron deficiency or any gastrointestinal side effects that would need to be corrected, it is unrealistic to believe that they're going to take therapeutic doses of oral iron when 70% don't tolerate it well. In those areas where we have comparative studies, you will see that there is no difference in safety or efficacy among the available formulations. Now, since high molecular weight iron dextran is gone, for the rest of this talk, I will assume that iron sucrose, ferric gluconate, Ferumoxytol, low molecular weight iron dextran, and ferric carboxymaltose have equivalent safety and efficacy across all prospective, retrospective, observational, intra-institutional studies extant. Now, let's move towards IV iron safety. You all learned it was dangerous. Every one of you went to medical school, said there's anaphylaxis, people die from this, and you're talking about treating iron deficiency, not cancer. That's a problem. There should never be a death with IV iron, and we'll talk about the management of the minor infusion reaction in a second. But this terrific study that was published by Avni et al., it was published in Mayo Clinic Proceedings a couple of years ago, looked at 103 trials, over 10,000 patients, and IV iron was compared to no iron, oral iron, and placebo, and even IM iron, which parenthetically should never be given. There's no advantage. It hurts. It stains the buttock. It has no safety or efficacy advantage and requires multiple injections, and it's cruel, so don't do it. There was no increased signal with intravenous iron in terms of increased SAEs compared to any of the comparators. There were infusion reactions. They are minor, but there was no difference in either efficacy or toxicity among the available formulations that were studied. Now, what I just told you was recently called into question by a large retrospective study done by FDA, published in JAMA in 2015. They enrolled over 688,000 patients. It's a big number. It was a retrospective study. SAEs were extremely rare, but they concluded that anaphylaxis was more likely with iron dextran, with iron sucrose. I disagree with that conclusion. I'm going to show you why this is polemic and controversial on my part. During the study, they were unable to distinguish between high and low molecular weight iron dextran, both of which were available during the study. The overwhelming preponderance of evidence suggests that the high molecular weight product was quite dangerous. It's been gone since 2011, I believe. The administration of Benadryl and epinephrine were actually used as a surrogate. So if you were a Medicare patient, you had IV iron, and you received Benadryl as pre-medication, which should never be done, by the way, you were considered to have anaphylaxis. The average age was in the 70s, so that means you lost everybody with heavy uterine bleeding, pregnancy, bariatric surgery, and inflammatory bowel disease, by and large, and excluded dialysis patients who were the lion's share of people who received iron sucrose. Nonetheless, SAEs were extremely rare. However, and I don't have the slide for this just for time, from their own supplemental material online, the risk of death was at least an order of magnitude lower with low molecular weight iron dextran with any of the other formulations on the day of administration, which effectively contradicts the conclusion because the reactions that lead to anaphylaxis occur immediately and not the next day. And that was supported by a recent KDIGO iron management program for iron safety, which said there is no physiologic basis to recommend the observation of any patient receiving iron for 30 minutes after the infusion is completed. However, you enroll 688,000 patients in an analysis. I think it's disrespectful to ignore it, and we appreciate the caution the FDA recommends. So look at this table from this wonderful paper published by Rampton et al. In Hematologica 2 years ago that gives you an algorithm for the management of these minor reactions. And the reaction that is flushing in the face or pressure in the chest without hypotension, stridor, wheezing, or periorbital edema, you should relax, let it resolve. Without therapy, do not give an antihistamine which can cause hypotension, somnolence, diaphoresis, and tachycardia. And when the symptoms resolve, with or without pre-medication with a steroid, you can re-challenge, and it's very rare for it to recur. In the extremely rare situation where you do have symptoms of wheezing, stridor, and hypotension, those are the symptoms that can lead to anaphylaxis, and you need to be prepared to deal with it. I haven't had to since 1997, when low molecular weight iron dextran was unavailable for a short period, and I gave 2 doses of high molecular weight. One of them went to the ICU, and 4 months later received low molecular weight iron dextran uneventfully. So, try to forget everything I just told you. And imagine that the patient on your left, who's also the patient on the right, who asked that I not black out his eyes, by the way, who had esophageal cancer, radiation esophagitis, a lot of bleeding, and serious iron deficiency, was given a dose of one of the formulations, and I'm not going to tell you which one because it doesn't matter because they're equal in frequency. He turned bright red, blood pressure went up a little bit, a lot of anxiety, pressure in the chest and back. You're going to think that's anaphylaxis. You are. And it would be reasonable for you to do so because it was the way you were taught. You intervene in this 72-year-old man with diphenhydramine and epinephrine, and you convert this minor, self-limited harmless infusion reaction into a hemodynamically significant serious adverse event, and the iron gets blamed. I have reviewed thousands of reported adverse events to FDA through the Freedom of Information Act, and the overwhelming majority of SAEs are probably due to imprudent physician intervention for this minor reaction. On the left, you see him 3.5 minutes later without treatment. We did pre-medicate him with a steroid, re-challenged him with the same drug, which was administered over the balance of the prescribed time, and it was tolerated beautifully. That's probably the most important message that you can take from this talk. So now let's move on to a few conditions where a single-dose infusion of IV iron is a clear step forward, either multiple doses of either iron sucrose or ferric gluconate, or oral iron. In pregnancy, iron deficiency is no small problem. There's a statistically significant increment in both cognitive and behavioral abnormalities in iron-deficient neonates that persist after 10 years after they're born. And there's an increase in neonatal brain growth and development. There's an increment in cesarean sections and in perinatal outcomes, including low birth weight and small for gestational age. And there are estimates that iron deficiency anemia is present in up to 30% of pregnant women. It's probably much higher iron deficiency without anemia. And currently, the United States Preventative Services Task Force says that there's insufficient evidence to recommend routine screening because we don't know what the negative effects are. And so I'd like someone to tell me the negative effect of checking iron parameters in a newly diagnosed gravida, but those are our current guidelines. So oral iron is miserable in up to 70% of people to whom it's prescribed, and it is miserable. If you take care of pregnant women, they will tell you how uncomfortable oral iron makes them, especially with constipation, which is already present because of the high progesterone levels which slow bowel transit and the enlarging uterus pressing posteriorly on the rectum. Intravenous iron in numerous publications show the safety and efficacy of IV iron during pregnancy. Its use is sporadic. No formulation has the highest level of safety by FDA, and the excessive fears by OBGYNs in an already highly litigious population of doctors limit the use of this. There is a misperception about the incidence and severity of reactions, and there isn't a single SAE reported in one study of IV iron in pregnancy, not one SAE. Here is a study that we published in 189 consecutive oral iron intolerant gravidas, and you can see a significant change in MCV and in hemoglobin from the time of administration to the time of delivery with a p-value with 92% achieving an improved hemoglobin and a p-value of 0.0039. There were no serious adverse events. This is published in the American Journal of Hematology last year. 4 patients had minor infusion reactions causing interruption, and the remainder received the balance of 1,000 milligrams in the balance of an hour. So in effect, we're really giving a gram in about 45 to 50 minutes. The results in the postpartum data, when available, were statistically significant at a p-value of 0.0001 with sustained increments in hemoglobin that are unlikely and unrealistic with oral iron, given the side effect profile. In bariatric surgery in the United States, for some incomprehensible reason, intravenous iron is not frontline care. This is a cartoon given to me by Jerry Spivak from Hopkins. In the stomach, when you swallow iron, it needs to be conjugated to vitamin C, amino acids, and sugars, so it avoids the massive alkaline rush in the proximal duodenum, where it gets converted to ferric hydroxide, which is rust, and cannot be absorbed. These patients have an obligate need for IV iron, as especially menstruating women, and that is supported by this paper from Gesquire et al., where over 70% of bariatric surgery patients develop full iron deficiency anemia within the first 5 years of the surgery. Now, this is a busy slide, but it's going to be less busy in a second as we're going to put in colors. The red slides are oral iron and are IV iron, and the blue slides oral iron. In the green, you can see where there is a comparison. You can take a look in any study that is published so far comparing oral to IV iron in this patient population. There is an enormous increment in response rate without the perturbations caused by oral iron in a population of patients who already have significant GI issues as a result of the rerouting. This was supported by a study that we did in our practice of 1,020 milligrams of Ferumoxytol, clearly off-label. It's a great way to give the drug, 15 minutes of 2 vials, but you make sure that you're approved before you give it, because this is $636 a gram. And it is off-label and often denied. And you can see that there's a marvelous response at week 4 and an ongoing at week 8. In this population, I believe we had 30% of the patients had gastric bypass. We have a very large population that are sent to us by the bariatric surgeons in our community. In inflammatory bowel disease, there's a clear disagreement between the use of intravenous iron in the United States and in Europe. In Europe, it's frontline therapy. In the United States, there is a consideration that oral iron can be tried. However, in patients with inflammatory bowel disease, oral iron, independent of anemia, is associated with severe side effects, results in low absorption, has limited efficacy, is associated with worsening of the bowel symptoms, and has been shown independently to worsen the pathological findings of inflammatory bowel disease and alter the flora negatively in patients with IBD compared to IV iron. Intravenous iron in every study that I have read so far at any point along the curve is associated with a more rapid and higher response of hemoglobin without all of the side effects. Here you see ferric carboxymaltose compared to ferrous sulfate. Here you see iron isomaltoside, which is a drug that's only approved in Europe. And you can see very similar result, by the way, in an indigent population in India. So you're dealing with patients with a lot of comorbidity as well. These are data from our practice where we gave 1,000 milligrams of low molecular weight iron dextran in 1 hour. The iron was diluted in 250 milligrams. The test dose was done. This is 1,266 infusions in 888 patients. And as you can see, 51% had a gram increment, 26% had a 2-gram increment, and only 1 patient was transfused due to GI bleeding. And these data are published in the American Journal of Medicine and gave rise to the agreement of the up-to-date editors that this was a prudent means of giving intravenous iron. Consistent with all of other studies published, there were no serious adverse events. You can see that only a very small portion of the patients had minor infusion reactions, all of which resolved. There wasn't one serious adverse event in the 1,266 infusions. Now, I'm going to close with something that you don't see, I don't think. But these data are so cool and high quality that I thought I'd show them to you. Intravenous iron prevents mountain sickness. I didn't know it. This is a paper from Peter Robbins' lab at Oxford showing that prior to an ascent to 4,340 meters in Peru, patients were given IV iron with with iron sucrose or placebo. And as you can see, using the Lake Louise score, which is the score for acute mountain sickness, there was a significant attenuation of the abnormality in patients who received IV iron. And this was just published in JCI from the same group. How they got people to do this, I don't know. But the patients were subjected to 2 6-hour hypoxia chambers, isocapnic hypoxia, 6 hours. And their pulmonary artery pressures were measured. The red were iron deficient, the blue were not. And you can see the significant attenuation in the second and the third graphs with IV iron compared to saline. So it probably hasn't caught on yet, but my guess is that the mountain climbing world is going to embrace this evidence, because it really looks like if you're going up to more than 15,000 feet, you should. And just again, on a personal note, my son was in special forces in the Israeli army and wanted to clear his head after the Gaza war and decided to go to the Himalayas. And I called Robbins, and he turned me on to his clinical guy. He says, if it's my boy, he gets a gram of iron. My son got a gram of iron over an hour before he left, didn't get mountain sickness, so there's your proof. So I'm done. Colleagues, you treat these folks. I don't think it's fair that I made stuff up today. You know what it's like to treat patients with inflammatory bowel disease with oral iron. It's cruel. In the perioperative state, oral iron is miserable. In peri and postpartum state, oral iron makes patients very uncomfortable. Gastric bypass, it doesn't work. In hereditary hemorrhagic telangiectasia, it doesn't keep up. We didn't have time to talk about restless legs, but there's a huge relationship between restless legs and intravenous iron. Oral iron barely works. Iron sucrose works okay, but single-dose infusions work much better. These are miserable symptoms. These folks stay up at night. They can't sleep. They have to get up and move, and then now prior to an ascent. So I hope I made you think about a paradigm that will change the way you approach iron deficiency anemia. We need to move IV iron closer to the front and make sure that people don't overreact to these minor infusion reactions that are harmless. Thanks very much.